All right, Assalamu alaikum everyone. My name is Faaez Syed, and the topic of discussion today will be about the clinical enzymology, and this was given by Dr. Ahmed Al-Jada in your MOM course. So what we're gonna do is that we'll go over the slides. Initially, we'll begin with a quick summary about what do we know about the enzymes. Then we'll discuss in more details about the functions of the enzymes, what role do they play in medicine, what are the different functions, where do we use them, do we use for diagnosis, do we use for treatment, what are their different functions, what are the different enzymes which are there in the specific disease states that we look for to diagnose certain conditions. So let's begin with just a quick brief up about the enzymes. So we know the enzymes are basically proteins, right? So we have the similar pathway for protein transcription. So we start from your DNA, we have the genes, we have the transcription, we make an mRNA, and from the mRNA, we undergo translation, we make the proteins, and these are basically the same proteins that undergo their specific modification and turn into enzymes. Now, whenever you see an enzyme, it's basically a protein which has some ability to carry out a reaction. So we have a substrate, so we convert the substrate into a product. So this is the function of an enzyme. So we have substrates, we convert them into your products. So the rate, then the enzymes have different characteristics. They have their specific rates. Uh, we have certain activators or inhibitors of these enzymes, which can change the rate of the reaction. It might even increase the rate, decrease the rate, inhibit the enzymes, and so on. So that's basically about the enzymes. Just to give you you guys a brief idea about it. Now we'll move on to discuss about the enzymology. So I believe most of the points we discussed, so they are basically biological catalysis. They are very efficient in carrying out the reactions, and then they are mostly proteins. They are specific to substrate. We'll discuss all of this. They are specific to tissues. Most of them are specific to tissues. There are some which are like common to all the body. And then you can measure the rate of the specific reaction of the enzymes. Measurement of serum enzymes. Okay, I forgot to mention, if you have any questions, you can just mention in the chat and then I'll be more than happy to answer it. So diagnostic enzymology. So enzymes are normally intracellular and they are low in concentration in the blood. This is helpful for us because if we perform a blood test and we see an enzyme levels which are either decreased or increased more than their reference range, we know that something is wrong with the specific tissues that these enzymes are present in. So this can help in diagnosing conditions. So enzyme release or leakage in the blood indicates a cell damage. So we know the enzymes are present inside the cells, and if there is a damage to the cell membrane or the cells in general, then they are leaked into the circulation and they are detected from our blood test. They are fairly non-invasive procedures because you just have to do a blood test and you will get all levels. Right? So you can do these tests very easily, so you can also repeat these. So again, this is helpful for us because suppose we have an invasive procedure, we cannot do it a lot of times versus these tests. We can repeat the blood test and it's fairly easy for us to get the enzyme levels. This can help us in diagnosis, in assessing the treatment response, in assessing the prognosis of the disease, all of this. The other feature of enzymes are organ specific, but not absolute specific, as I mentioned. So they are known to be present in certain tissues, in certain cells, but not always true. They can be present in more than one tissues, like an enzyme can be present in the liver and So it can be present in the muscle, or it can be present in the heart. So although it has a specificity, but this is not always true. Most enzymes are present in most cells, but their amounts is different. Okay, so information can from the enzyme measurements in the serum. So we can detect there is any disease going on, right? If the level of enzyme is differing from their reference, there's something wrong going on. We can determine the organs involved. So as we mentioned before, so certain enzymes are present in certain tissues. So we'll know that, okay, so this enzyme is present in this tissue, so something is wrong with this tissue specifically. We can make a differential diagnosis by this measurement of the enzymes. Extent of disease, more damaged cells, more leaked enzymes in the blood. Makes sense. If more cells are damaged, more enzymes are leaked, the enzyme levels will hike up. The time course of the disease can be estimated as well. What do we mean by isozymes? Isozymes are basically the same enzyme, but they're different structure. So they perform the same function, but they have slight changes in their characteristics, okay? So they catalyze the same reactions, but are formed from structurally different polypeptides. They perform the same function. We have different isozymes in different tissues. What are their different characteristics? Mainly, they differ by their enzymatic properties. They differ by their physical properties, like their heat stability and so on. They differ in their amino acid composition. So these are mainly their differences, but they more or less carry out the same function. Remember this isozyme concept. We'll discuss more in detail later on about the specific enzymes and their isozymes. Now the application of enzymes. So I gave a brief about this concept. So the enzymes, we can use them for diagnosis. We can use them for therapeutic application. We can use in laboratories to detect something. So the majority of the lecture will be focusing on the diagnostic part, because this is the most important to us. Then we have a few examples of therapeutic application and a few examples of your laboratory application. So what do we mean by diagnostic? So the coming slides, we will be just discussing about the diagnostic application of enzymes. Diagnostic importance of plasma enzymes or clinical enzymology. We have two kinds of enzymes now. We have the functional enzymes. What do we mean by functional enzyme is that these are mainly present in the blood, in the bloodstream, in the serum. So they have their specific roles in the serum. Like we have blood clotting factors. So this is one example. So they are functional enzymes. They have certain functions inside the blood. Whereas we have the non-functional enzymes, that means there is no role of this enzyme in the blood, but their role, their function is mainly in certain tissues, like the heart, like the liver, muscles, and so on. Why they are present in the blood is because there was some damage to the liver or the heart or the muscle, and they are spilled into the blood. So now we call them as non-functional enzymes. Examples, there are multiple examples. Uh, so if you see here, functional enzymes, their function in the plasma, they have a specific function. What is the concentration? They are present in large concentration because that's their major role. They are present in the blood to cause some functions. What is the importance when plasma levels are increase or decrease? Mainly because if it's decreased, because if the concentration is large, that means if it goes down, this is for clinical importance. Whereas on the other hand, we have other example of non-functional enzymes we'll discuss. What are the examples of functional enzyme? We said the blood clotting factors, ceruloplasmin, something which is present inside the blood. Let's take the non-functional enzymes now. So they have no specific function inside the blood. So their main function is in the tissues, in the heart, in the muscles, and so on. So their concentration is in the plasma is small. So whenever you see a hike, an increase in the concentration levels, we know that, okay, something is wrong in these tissues, okay? So clinical importance when the plasma levels are increased. So whenever the levels go up, we know something is wrong. So where do we get these enzymes from? Tissue destruction, necrosis, apoptosis, and so on. All right, so this is just another example. So here we have the low plasma enzyme levels. This is your normal wear and tear of the tissues. This will spill only low levels of the enzymes. Whereas if you have increased wear and tear of the tissues, this might happen in cancer cells or any disease states, you will have increase in the plasma enzyme levels. We have multiple examples. We have LDH, we have creatine phosphokinase, ALP, AST, ALT, amylase, lipase, blah, blah, blah. It just goes on, okay? So let's see, plasma enzymes, if they are higher than normal, they come either from your cell damage or increase in your cell proliferation. Whereas on the other hand, if the plasma enzymes are less than the normal, this mainly comes from your inherited deficiency. They were born with this, like they might be having autosomal recessive diseases, so they have lack of certain enzymes, or it might be just because of decrease in the synthesis of the enzyme. So that's why we are detecting low levels. So enzymes in diseases, they can be categorized into two. Okay, so the first one is we have abnormal level of enzyme, which is because of a disease. So we have a disease which is causing a decrease or abnormal level of the enzyme. Okay, so disease is first. The enzyme levels are reflecting the disease states. So this is the first one. Whereas on the other hand, the second one is because we have abnormal enzyme activity. This is coming from a trauma, from a disease. Okay, so two, again, I'll explain it again. We have two conditions. Either the disease is causing the abnormal enzymatic activity, abnormal enzyme levels because of the disease, or the other condition is the abnormal level of the enzymes is causing the disease. Okay, so the inborn errors of metabolism, this is what happens. They are born with a condition where they have problems with the enzyme synthesis or the enzyme production. So this lack of enzyme is causing the disease state. Okay, so if you see here, where the abnormal level of enzyme is the fundamental cause of the disease. So this is one condition. The other condition is because of the disease or because of the trauma, there is an abnormal enzyme levels. Makes sense. Okay. So let's pick this one, okay? So let's talk about this one, the inherited errors of metabolism. What happens here? So in inherited enzyme deficiencies, there is an inherited absence or mutations in the enzymes, and these are referred to as your inborn errors of metabolism. There's accumulation. Obviously, if the enzymes are not working, they are not functioning properly, the substrates will accumulate and the products will decrease, right? As makes sense because the enzymes are not working. So there will be accumulation of the substrate, and this accumulation of the substrate are the ones that causes the disease states. Majority of the times, and then we have decrease in the product, which can cause the disease manifestations as well. But this accumulation of substrate is dangerous, can be dangerous in certain diseases. Most inborn errors of metabolism manifest after birth because of the exchange of metabolites between the mother and the fetus in utero. Therapeutic strategies for enzyme deficiency diseases include dietary modifications. So the first thing is you have to modify their diet. If they are deficient in certain enzymes, we don't give a substrate as their diet. So we replace this substrate with something else so that they don't no longer require the enzyme for the conversion of the substrate. That's the first thing. And you have to supplement them with the products because they're not able to make the products from this enzyme deficiency. So you have to modify their diet in such a way that you decrease the substrate and you give them the products directly. So what are the products? It might depend on the different enzyme that are deficient. What are the other possible treatment options? You can go for gene therapy, or you can directly replace the enzyme in these patients. So these are just one example of the inherited enzyme deficiency. This happens in so the category of these diseases is known as sphingolipidosis. This happens because of your accumulation of your sphingolipids. Different enzymes can cause, different deficiencies of the enzymes can cause different diseases. So it depends on which enzyme is deficient. that will end up causing a certain disease. You don't have to know the details at your level, but later on, you will have to memorize each one of them because this is very high yield. There is not a single like step one exam or NBMEs or any practice exams that you will give later on without a question on these diseases. So it's very, very important later on, not at your level. Okay, so what are the principal diagnostic enzymes that you have to know? So I believe like the coming few slides are the most important for you guys. What you have to know is that if we are talking about an enzyme, what is their location? So that's more important. So if you do a lab test and you see a hike in ALT and AST, then automatically you should think about that. Okay, there is increase in ALT, there is increase in AST, and we know that ALT and AST are found predominantly in your liver. So there's something wrong with the liver. So you have to know this at your level. Okay. So what are the different enzymes which are increased in disease states? So like, let's take each one of them and where they are present. Normal plasma level, you don't have to know it. More often they should be given in the exam. So ALT and AST. So we usually tell them together, like ALT, AST, they are usually present in the liver. So any increase in ALT or AST goes with the liver diseases. We have some AST in the heart as well. So that's why the ALT is more specific for your liver diseases. So I believe this is important because I saw a question as well related to this one. So ALT is specific to liver diseases. And even in early liver diseases, if a patient is having, suppose, any hepatitis and so on, they mainly present with an elevated ALT more than the AST. There are only specific conditions, like if a patient is alcoholic and he's having a liver disease because of alcohol consumption. So this is an exception in which the AST will go higher than the ALT, but normally it's the ALT which is higher than the AST, even in liver diseases. Then we have the creatine phosphokinase or creatine kinase. The function of this enzyme is that to provide rapid energy to the muscles in terms of utilization. Like if you're exercising, if you're running suddenly. So this is one source of energy with the help of the phosphate. So they are mainly present in your muscle. So they might indicate your muscle disorders or crush injuries. Creatine kinase will go up. And there are certain isoforms of creatine kinase which are present in the heart. So that's why if there is a rise in CKMB, which is present in the heart, CKMB is present. So if there is a rise in CKMB, we use it for diagnosing any heart problems like MI, specifically myocardial infarction. Lactate dehydrogenase, again, they are present inside the cells. Specifically in the heart muscles, in the skeletal muscles. So if there is increase in the lactate dehydrogenase, we might suspect something wrong with the muscles or MI. Also, lactate dehydrogenase is present in the RBCs. They have a major role in RBCs. So if there is hemolysis, the LDH will go up. This is very important as well. Alkaline phosphatase, mainly when we talk about alkaline phosphatase, there are two places that you have to know. One is the bile, so biliary duct and all that stuff. So if there's any damage to the bile duct, bile system, the alkaline phosphatase will go up and the GGT will go up. So these are the two important ones. And the second one for alkaline phosphatase is your bone. So any bone disorders, the alkaline phosphatase, we look at the alkaline phosphatase because alkaline phosphatase and acid phosphatase, if you see both of this is involved in your bone regulation. So alkaline phosphatase is important for bone deposition, whereas acid phosphatase is important for your bone reabsorption. So alkaline phosphatase, that's why we look in bone disorders. Acid phosphatase, we look in prostate cancer because prostate cancer tends to metastasize to the bone. So this might indicate our bone pathologies. Amylase and lipase are very important for your pancreatitis, specifically the lipase. The lipase, we look for pancreatitis. It is a diagnostic criteria for pancreatitis. If the lipase levels goes 3 times, then it is a diagnostic criteria. So very specific to pancreatitis is your lipase. We also use amylase, but it is not very specific. GGT, as I already told you, GGT goes along with the alkaline phosphatase. We look in mainly in the biliary problems, so any bile problems, any other liver diseases, we look at the GGT. All right, so till now we were discussing the enzymes that increases in disease states. Now let's discuss the enzymes which decrease in the disease states. There are other enzymes as well, but the only one that's mentioned here is ceruloplasmin. Ceruloplasmin is, you can say it as a carrier of copper. So what happens is that in Wilson's disease, there is decrease in this ceruloplasmin by the liver. So the liver is not able to make enough ceruloplasmin or not able to transfer the copper to ceruloplasmin. So this ceruloplasmin is not transporting the copper inside the blood vessels. So all of this copper is accumulating in the liver and causing the a disease in the liver. So just know that ceruloplasmin is usually tested if a patient is having Wilson's disease. So the levels usually decrease, okay? So in Wilson's disease, the ceruloplasmin levels decreases, just know this. Whenever we are suspecting a disease, like a liver disease, a kidney disease, or a thyroid disease, we don't order just one test. We just don't order like AST. We order a whole set of tests like AST, ALT, alkaline phosphatase, GGT, and so on. So when you order multiple tests, this is known as a profile. So this is known as your hepatic profile, renal profile, thyroid profile, and so on. So whenever you order a profile, this is indicating multiple tests. So for accurate diagnosis of particular disease, more than one serum enzyme are routinely estimated instead of a single enzyme. Just to know that what the disease, how the disease is progressing, how it is affecting the person. And it also helps us with forming our differential diagnosis. Like if AST is more than the ALT, then we know that, okay, this person might be alcoholic. If the alkaline phosphatase or the GGT is more than your AST, ALT, then we know that, okay, it's not proper liver disease. It might be something related to your bile system. So that's why a profile is used. A few examples of the disease and their enzymes that we look at. So myocardial infarction, there is CKMB that we look at, AST, LDH. In liver diseases, we have ALT, AST, ALP, GGT, LDH. So this is the whole liver profile that we look at. In muscle disorders, we may look at the CK, the creatine kinase. There's also LDH and the AST, which is present in the muscles. So any rise in these will indicate that, okay, something is wrong, probably with the muscle, because these specific isozymes, they are present in the muscles. Bone disorders, we look at the alkaline phosphatase, as we discussed before, because alkaline phosphatase is important for your bone deposition. So what are the different bone diseases? We have Paget disease, we have rickets, osteomalacia, osteoblastoma. All of these are related to your bone pathologies. Pancreatic diseases, we have two. We have amylase and we have the lipase. Lipase is more specific, as we discussed before, for pancreatitis. So marked increase 5 to 10 times will indicate there is acute pancreatitis, and this might also indicate glomerular impairment. Moderate increase up to only 5 times might indicate certain other pathologies like peptic ulcers, cholecystitis, intestinal obstruction, salivary gland disorders. That's why the amylase is not very specific. That's why we use lipase, because amylase can be elevated in all of these conditions. Let's talk briefly about the creatine kinase and the different isozymes of creatine kinase. So the function of creatine kinase we discussed before is that it is used to provide rapid energy. So the rapid energy is coming in the form of your phosphocreatine. So we have creatine plus ATP will give your phosphocreatine and ADP. This phosphocreatine is the one that provides the rapid energy. to the muscles when the muscles are contracting. And the enzyme which carries out this reaction is your creatine kinase. So creatine kinase is dimer made of two monomers. We have M and we have the B subunit. Depending on their composition, we have the different isozymes, and different isozymes are present in different tissues. So if it's mainly composed of your B and B subunit, they are mainly present in the brain. MB is present in your heart. So that's why in myocardial infarction, we have CKMB that we looked at. And then we have the M and M, which is present in the skeletal muscle and also some in the heart as well. Let's talk about LDH. LDH catalyzes the reversible conversion of lactate to pyruvate. If you are like comfortable with the how the lactic acid is made, you will know where we get the pyruvate from. So we have the glycolysis pathway, and then we make pyruvate, and then pyruvate is converted to acetyl-CoA, and then it goes into your citric acid cycle. But if there is any accumulation or any thing going wrong, then we shift the pyruvate to form lactate. And the enzyme that catalyzes this reaction is your lactate dehydrogenase. Increased total LDH is relatively non-specific. Why? Because obviously you have different isozymes. LDH isozymes can be useful. So 5 isozymes composed of cardiac and muscle component. So we have all H in your cardiac and RBCs. We have then combination of H and M depending on the different tissues. So LDH is also used in myocardial infarction, not so much these days. This was mainly previously, but now we mainly depend on troponin I. We depend on CKMB, and then also the myoglobin, which is the first one to go up. So these are the major ones, not so much on LDH. I don't know, at least I don't know about the LDH that are used. So LDH increases 12 to 24 hours. Post-MI peaks at 48 to 72, remains elevated for 10 days. The specificity and sensitivity are 90+% within 24 hours of MI. What you have to know is here. So if you do electrophoresis, these are the different LDH levels, LDH 1, 2, 3, 4, 5. Normally what happens is that the LDH2 is more than the LDH1. But in states of myocardial infarction, the LDH1 will be more than the LDH2. And as soon as you see LDH1 more than the LDH2, you know that something is abnormal. And this might indicate myocardial infarction. So normally the LDH1 to total LDH ratio is less than 40%. LDH1 more than LDH2 is consistent with acute myocardial infarction. Okay, now let's talk about the ALT and the AST. ALT and AST, they are mainly present in the liver, they are mainly present in the muscles. What is the function? They carry out this reaction, which is going from your aspartate and oxoglutarate or ketoglutarate, alpha ketoglutarate, if you know that. So it's probably referring to the same one. So aspartate and alpha ketoglutarate converting to glutamate and oxaloacetate. This is your aspartate aminotransferase, as the name suggests, aspartate. Whereas alanine aminotransferase converting alanine and alpha ketoglutarate to glutamate and pyruvate. So where do we use this? We mainly use for transporting the alanine. So what happens in the liver is that we convert the glutamate and the pyruvate into alanine, and then the alanine is transported in the blood and it goes to the peripheral tissues. And in the peripheral tissues like the muscles, the alanine is converted back into glutamate and pyruvate, and then this glutamate and pyruvate is used for energy. We know that the pyruvate, it will go to form acetyl-CoA and then the Krebs cycle, and the energy is made from this pyruvate. So that's why we convert them for mainly transporting. ALT and AST are the most abundantly present in the liver and are elevated in blood as a result of leakage from the damaged cells. Measurement of these transaminases is useful diagnosis of liver diseases. In viral hepatitis, the levels can go up to 20 to 50 times above the upper limit of the normal range. ALT is more specific for hepatocellular damage. AST is moderately increased in muscular dystrophy, and AMI, that's why it is not very specific to your liver disease. What does an ideal cardiac marker? So whenever we talk about a diagnostic test, it could be anything, any diagnostic test like a CT scan, X-ray, uh, CBC, anything that we talk about, they need to have certain relevance. Like they need to have a good sensitivity. They need to have a good specificity. Sensitivity in the sense like, okay, if there is a disease going on, I should be able to sense the level of this enzyme or the disease state. Okay, so this is the sensitivity. Specificity means that, okay, I found this enzyme. Now I should be sure that this rising enzyme is specific to this tissue. So this is your specificity. So if you see here, absence in non-myocardial tissue, if we are talking about cardiac marker, it is highly specific if it is absent in the non-myocardial tissue. Makes sense. If a marker is increased and it is highly specific, then it should indicate me that, okay, this marker is specific for the heart. So that's why it is highly specific. So we talked about high sensitivity, high specificity. What about the other characteristics that we have to know? One of them is cost-effective method. Not all hospitals can afford all the tests, so it has to be a cost-effective. It should give good results, so it should be simple to perform. It should have quick results. It should have a good precision. It should have a good accuracy. And the last important characteristic is that it should be able to influence the therapy. Like if I am testing someone for a blood test or anything, that should help me with my diagnosis or help me with my treatment or help me to guide the response of the treatment. So all of this will include your ideal markers. So these characters should be present. All right, moving on. Let's talk about the cardiac enzymes. So as I just told you before, like cardiac enzymes are not used that much as compared to before. So nowadays we mainly depend on the troponin, we depend on myoglobin, and we depend on the CKMB. So these three are the most important ones: troponin I, myoglobin, CKMB. If you want to know quick facts about these three, just know that the troponin I is widely used for diagnosing myocardial infarction. So it has the highest specificity. So I believe it has the highest specificity, but it is the most oftenly used for the most dependent. So troponin I for your myocardial infarction. Myoglobin is the first one to rise. So if a question asks which marker goes first in a patient with myocardial infarction, you should select myoglobin. So myoglobin is the first one to rise. We discussed troponin I. This is the most important one for myocardial infarction. And the third one is your CKMB. CKMB is used in patients and it will indicate if there is any reinfarction. Okay, so any reinfarction, like a patient presented with myocardial infarction, the patient is admitted. Now it has been 4 days since the infarction happened, the treatment is going on, and so on. So now the patient is again having symptoms of infarction. So now we cannot rely on troponin because the troponin will be elevated for a prolonged period of time. So it will be elevated for days. So we cannot depend on troponin I for diagnosing myocardial infarction. So now we have to depend on a different marker, which is CKMB. So CKMB is the one that goes up quickly, goes down quickly as well. So if a patient is having an infarction here, like 3 or 4 days after, then the CKMB will go up again. So we know that, okay, now CKMB is going up, so this patient might be having reinfarction. So again, troponin I for myocardial infarction. First time myocardial infarction, you look at the troponin I. Myoglobin, the first one to go up. CKMB for reinfarction, okay? So important points. So again, if you see here, the red one is the CKMB. I don't know why it's in yellow. So CKMB, sorry, not CKMB, the myoglobin, because we said this is the first one to go up. So myoglobin goes up. Then we have the green one is your CKMB. It goes up quickly, goes down quickly. Then the troponin I will be elevated for a long period of time. So that's why we cannot depend on troponin I for reinfarctions. Again, the same thing that I talked about. So myoglobin is the first one to go up. and goes down quickly. Troponin I, it goes up slowly, but it remains elevated for a long period of time. So normally it's 6 to 10 days. Uh, and the CKMB, it goes up and goes down quickly in 12 to actually 72 hours it goes down. So the interpretation of cardiac markers can be difficult because blood specimens are not always collected soon after the patient suffers chest pain. So that's why history is very important. So since when the patient is having the chest pain, is it 1 hour, 2 hour, 24 hours, like, or 48 hours? It depends. So we need to ask a good history. Uh, Delay of hours to days are common before patients seek medical attention. If a patient is having severe symptoms, then it's normal to present in the emergency department. But if a patient is having not so severe symptoms, it's just a mild chest pain, um, and the patient can just ignore it. So in these cases, it will be very difficult to diagnose these patients. Okay, so far we talked about the diagnostic application of the enzymes. So this was the majority of the lecture. Now we are moving on to the other features of the enzymes, like your therapeutic application and your laboratory applications. So let's quickly talk about the therapeutic applications. So specific enzymes are administered to patients for treatment purposes. So the examples include your TPA, the tissue plasminogen activator, urokinase, streptokinase. So what it does is that it breaks down the clot. So it's important in myocardial infarction. It is important in DVT. It is important in stroke patients. So to break down the clots. So these enzymes are used. Tissue plasminogen activator, as the name suggests, it activates plasminogen to form plasmin, and the plasmin is the one that breaks down the fibrin into soluble products. Then the second application is asparaginase. Asparaginase is an enzyme which breaks down asparagine, and asparagine is important for your DNA formation. So if there is lack of asparagine, we are not able to form the DNA properly. So they are used as a chemotherapeutic agents. So they are used in leukemia. Trypsin and lipase, they are normally secreted from pancreas for digestion of your fats or your proteins. So if a patient is having pancreatic insufficiency, this might be because of many causes. So if a patient is having pancreatic insufficiency, we can administer these enzymes so that they function similarly to the enzymes which are normally present in the pancreas. Now, the third application of enzymes is your laboratory. So they are used in labs for specific functions, like estimation of concentration of certain substances in body fluids, like in plasma, CSF, etc. So we use the enzymes and then we see how much of the specific substance is present. They are used in DNA analysis techniques, like we use your endonucleases, the restriction endonucleases. We have polymerases that we use. So these are enzymes. They are just used for your DNA analysis. Then we have the ELISA technique or ELISA technique. So let's take the first example, the estimation of concentration. So what do? We add a specific enzyme which converts the substrates into products. And then we add a specific reagents which are helpful to which are used to detect. So the products might not be detected by our test, so for this reason we add certain reagents so that they change the color or do something so that we can detect them. DNA analysis techniques, the one that I mentioned, restriction endonucleases, polymerases, ligases, so they are used in DNA analysis techniques. This is specifically helpful in genetic diseases, infective diseases, and so on. And the last application is your ELISA technique. What we do, there are different ELISA techniques. We have the direct, indirect, sandwich method, so on. So the main concept behind ELISA technique is that to detect the specific antigen or to detect the antibody, we attach an enzyme to another antibody. And once this antibody is bound to the antigen, we add a substrate. So when we add a substrate, the enzyme which is attached to the antibody will convert the substrate into a product, and the product is detected either by color change or whatever different mechanisms. So ELISA technique utilizes the enzymes as tools along with antibodies in the measurement of certain proteins. And this is helpful in detecting certain viruses, indicating hormones, and so on. So I believe this is the last slide of the lecture. I hope it was an easy one as compared to your other lectures. Uh, if you have any questions, you can ask me. The floor is open. Yes, CKMB is more specific for MI. If you're talking about reinfarction, yes. So in reinfarction patients, you mainly look at the CKMB because CKMB is present in the heart. All right, you're welcome. You're welcome. I hope it was beneficial. Yes, troponin I is more specific for the first time. You're correct. Because troponin I stays elevated for a long period of time, so you can detect easily. Perfect. You're welcome. Any other questions you can ask me? I know mole is difficult, but inshallah, you will get it over soon. Um, so I believe if there are no other questions, then we can stop. Thank you so much.